It's a great pleasure to be invited to speak at such a wonderful venue. I'll apologise at the beginning that I practiced this talk over the last couple of days using something called presenter view, which for those of you who've done talks is a function of PowerPoint that puts your next slide in the top right-hand corner so that the speaker can appear smooth and eloquent and knows what's coming next. There is no presenter view on this laptop. So the expression of surprise on my face as each slide comes up will be genuine. Okay. So the death of a child is a seminal event. It has lifelong repercussions for the entire extended family and their friends who have to endure it. It has clear emotional impact on the staff who have cared for the child who has died, and also places in front of them a number of practical and logistical challenges. There's nothing really that health staff can do to make that experience better. But more than 15 years in the job that I do indicates to me that there are innumerable ways in which slips, deficits, and mistakes that we can make that experience considerably worse. The family's experience is impacted by the hospital and its staff in the following diagram. We'd like to think that all the healthcare professionals working in children's healthcare have the requisite professional skills to deal with any challenges that are placed in front of them. Children's healthcare professionals also regard themselves as nice people, and most of us are. So we would like to think that we naturally possess the empathy to recognize distress and grief in others and respond appropriately. The piece at the top is system competence, and that really represents the policies, the procedures, and the practice that describes the interaction with a family after the death of a child. And it's this system competence that represents most of the discussion that will follow. The interactions are obviously challenging because they come at a challenging time when the family are distraught and grief-stricken. And the topics that covered here, as I say, will follow over the next few minutes. Previously, there was very little guidance out there as to how to manage these sort of interactions. Some hospitals did this quite well, usually as a result of one or two healthcare professionals developing an interest in the area and responding appropriately, but other hospitals did this poorly, having no particular interest in it or no professional who wished to drive it. Happily, guidance now exists, and I don't need to tell anyone in this room about these guidelines coming from the Hospitals Friendly Hospital Group or the health service executive that produced guidance surrounding postmortem examinations some years ago. The standards that resulted are not mandatory and they're largely self-assessed, but compliance with these guidelines is clearly a worthy objective, and I suspect at some stage in the future aspects of them will indeed be mandatory. In Our Ladies in Crumlin, we've established an end-of-life care committee whose principal function is to implement those standards and to self-assess against them. But the committee also takes on all of the other aspects of end-of-life care within the hospital. It serves a very useful role, principally in defining responsibility for these aspects of hospital care, because when they're dissipated across all hospital services, they often end up being nobody's responsibility and not being tackled at all. So we'll start with the first challenge, which is just the care of the remains, the care of the child after death. Traditional offices involve washing the body or dressing the body and presenting the body to family. And some religious or ethnic groups have very specific requirements about this. In a multi-ethnic society that we're increasingly becoming, the principal mistake one can make is to assume that everybody needs to be handled in the same way. So I'd urge you to make no assumptions and to ask anybody who is there for advice. Particularly useful are religious leaders in communities that you're not familiar with or extended families. And I have a personal favorite, which is grannies. If there's a granny in the room, get her there, okay? Grannies are experienced and they are pragmatic. They have usually faced death in the family and they are your strongest advocate. particularly because as a result of being one step removed from the child, they also have the parents' interests at heart. And sometimes the family who are so grief-stricken, they can't take on the responsibilities that are charged with them, and they're getting in their own way as a result of the grief. So granny in the room can usually solve lots of problems. It's extremely important that we facilitate access to the child after death. That was something intuitive that we've been doing in Cremation for a very long time, but there is now science to support that, and I'm grateful to Mary, who directed me to an Australian study that suggested that bereavement outcome is improved in circumstances where the family are facilitated in their wish to spend time with the remains after the death of a child. That places a number of practical challenges on a hospital or healthcare facility, particularly in more complicated, mixed up or broken families, or in large families, and where families are seeking to have access overnight. There are supervision challenges. How do we facilitate the family when there is also a post-mortem to be undertaken? How do we facilitate the family when there's an inevitable deterioration in the condition of the remains afterwards? And many healthcare facilities in the country are challenged to provide an appropriate physical environment in which to do that. Ideally, if you have a mortuary area that's appropriately set up, that's ideal. It removes the child from the ward, but many families have developed a very positive relationship with healthcare staff on a particular ward and are reluctant to move in that time. If we are going to move to a particular mortuary in order to facilitate access, then that necessitates transporting a child. And transporting a child through a hospital, a busy clinical area with parents and staff and visitors, also presents challenges. Because most mortuary areas were located, built, and kitted out long before this was a matter of concern, they're often very inappropriately located within a hospital, and this trip is a real challenge, a practical challenge on an almost daily basis. It's very difficult to balance the dignity and respect for the child and their family with the competing interests of trying not to disturb the rest of a hospital. Hopefully, future hospital designs, and obviously the National Children's Hospital is big in our mind on this, future hospitals can benefit from specific standards that have been produced to suggest how it should be done, and the transport from any part of the hospital to the mortuary should be part of that design process. So the HFH design and dignity standards suggest there should be visual, auditory, and olfactory segregation of a mortuary from patient areas and from the public and operational areas of a mortuary, with sufficient access and parking to facilitate families coming in and out. It's sad to report that the mortuary that was originally proposed in the Mater Hospital iteration of the Children's Hospital could meet no single one of those aspirations. We hope we will do better with the proposals that exist for the St. James's Hospital site, but it doesn't fill me with confidence that the first design of the hospital had no mortuary at all, and that we had to retrofit it into a small space that I think we would all acknowledge is not ideal. Identifying that the body of a child poses an infectious risk is obviously an emotive subject, but we can't get around it. There are circumstances in which the body does represent a genuine risk to healthcare workers, relatives, and funeral staff. No local guidelines existed to help healthcare professionals or mortuary directors in managing these, and for many years we had to look to the UK Health Service Advisory Committee or the Health and Safety Executive to direct our practice. The Ebola outbreak changed that in a hurry. There were lots of public health officials running around producing guidelines because of the possibility that we might meet somebody from West Africa over the last couple of years with Ebola. So there are now local guidelines. As with many things in medicine, common sense is actually your best friend rather than a printed guideline. And you can manage the risk by managing a restricted viewing, limiting the number of people without having to make a major fuss as to why you are so doing. And in the rare circumstances where a body bag is required, and sometimes it is, it may be partially unzipped and concealed to at least facilitate the immediate family members attending. there, in my opinion, is no ethical option but to inform funeral staff and those handling the body that there is an infectious risk. One obviously has to do so sensitively, but there is no ethical option but to do so. If we're going to transfer a patient from a ward to a mortuary, obviously we have to deal with lines and other medical devices, NG tubes, etc. If the patient is going straight home from the ward, you can do this on the ward. But if a postmortem examination is required, then those lines and medical devices may well have a significance to the pathologist, potentially even being a contributory factor to the cause of death. So there is a conflict between that sensitivity and the needs of the pathologist. My advice is to discuss with the pathologist first, if in doubt. We can usually reach some form of compromise which allows the family to sit with a child detached from all of these lines and devices. Often amputating the lines flush with the skin allows the pathologist to be happy that he or she knows where the lines were without being too obvious for a family caring for the child. Embalming is now increasingly sought by families, particularly in circumstances where there'll be a delay to the funeral or with a number of different nationalities now in the country. We're exporting more children home to be buried in Eastern Europe and other parts of the world. The HSE believe this is not a core duty of the health service executive and have indicated that they wish children to leave hospitals to have these done by undertakers in funeral homes. This was prompted by concerns about the quality of embalming being done in some locations. However, in my opinion, that's going to reduce the amount of time a family can spend with the child. It places an additional logistical challenge on them when we're trying to facilitate that access. A better solution, and one we put in place locally, is to develop a service-level agreement with a quality embalming service who can access the facilities in the hospital to ensure that we get a good quality service and that the family's time with the remains are maximised. Cremation is also increasingly sought. For anybody involved in organising a cremation, there are a number of forms and it takes a considerable period of time. It's a practical issue the family needs to be made aware of, and we need to be proactive about getting it done rapidly. There is also a practical issue around the ashes, particularly from a very small child. And this is currently the subject of a review in the United Kingdom amid concerns from the Department of Health that families are getting the wrong information about the ashes that remain after the cremation of an infant. We'll watch these recommendations with some interest. There are also some practical issues around indwelling devices that, again, the staff must be aware of before triggering a cremation. So the second practical topic then is postmortems, and I have two questions on the board here. The first one about coroner versus non-coroner, I'll come back to in a few moments, but the second one, who should perform the examination, should it be a specialist paediatric postmortem or should it be a general pathologist? Traditionally, most of the paediatric postmortems in the country were undertaken by general pathologists and were sufficient to identify the main benefits or to yield the main benefits of a postmortem, which is to find out the cause of death, to yield information for the family who may have questions about the care, to try and advance medical information and research and perform an audit function. There are circumstances where a specialist paediatric postmortem is clearly warranted. In the perinatal setting, any death around the immediate birth should have a specialist involved. Following any medical intervention, we should have a specialist involved, and following recurrent pregnancy losses, we should have a specialist involved. In the paediatric setting, any sudden or unexpected death, or any death from a rare or unusual paediatric condition that a general pathologist would have had very little experience with. These are categories of cases that we all agree should be a specialist postmortem, but you might be able to argue reasonably that any child or any family losing a child should be able to access this service. If that is the case, then there is a large unmet need currently in the country because there is very limited access to specialist paediatric pathology services. to such an extent that the Faculty of Pathology had a committee in 2009 that recommended a formal regionalised service. This was updated in 2014 to reflect the new hospital groupings, and this particular report has also been endorsed as the model of care for the NPH in a proposal in 2015. At the moment, we have the unenviable position of children dying in certain parts of the country in need of a specialist paediatric autopsy service where either the hospital staff or the coroner have to pick up the phone and ring around to try and find a pathologist willing to undertake a task they are not mandated specifically to do. And that's not a very tenable position. The report produces a very clear referral pathway for a child dying in any institution, so everyone knows before the death where this will end. For the perinatal groups, deaths, it's within the local hospital group, and the proposal, for example, that the Rotunda look after perinatal postmortems for the entire Dublin North East group is the prototype. Paediatric referral again would be initially within the group, with a secondary referral to Crumlin, Temple Street, or ultimately the National Paediatric Hospital, depending on geography or clinical condition. But no child would die in circumstances where a paediatric postmortem was necessary without everybody knowing beforehand where they would end up going if it was required. Sadly, of course, there's no money to implement any of this recommendation. If we're going to have a regionalised service and patients are going to be transferred for a postmortem examination, then we're going to have to deal with the logistics of transport, and that poses additional challenges. If we're going to bring the child, then the family are going to have to travel with the child, and in doing so, they're going to lose the support of their immediate family and friends that they will rely on most heavily at the time of the loss of a child. How do we support them out of their normal home environment? If the child is going to travel, then the pathologist is faced with performing an examination without access to most of the information that will be in the base hospital the child was treated in. How do we fix that information deficit? And if a child is transferred for postmortem, who is following up and supporting the family afterwards? Is it the hospital in which they died? Is it the hospital in which the postmortem was undertaken? Or is it both? Or occasionally, as seems to happen in the country, it's neither. And just as an aside to a community of palliative care professionals, we should point out that discharge home to palliative community services does not mean that the original hospital has no role to play in helping to manage the death of a child. And in particular, it does not preclude a postmortem examination where one is potentially of benefit. It does require that we actively manage the coroner beforehand, that you make contact with the coronial service in the local area, tell them what's happening, tell them what's planned, so that we can make the arrangements that are necessary to facilitate that examination where it's helpful. And we have managed to achieve that on a couple of occasions in Crumlin to good effect. Whether we have a post-mortem or not, there is an ongoing process of communication with the family. Next of kin clinics are the formal expression of that ongoing communication process, and were mentioned in the introduction by Eleanor. The next of kin clinics have three principal functions. One is to provide information about the death of the child. The second is to answer questions for the family as openly and transparently as we can. And the third is to provide an opportunity for bereavement specialists to assess and support the family's grief process. In Crumlin, where a postmortem has been performed, myself and my colleague Maureen are part of these next of kin clinics and often take the lead in them. A more challenging discussion takes place earlier in the process, and that is where a postmortem has to be undertaken, and we are communicating with the family in the immediate aftermath of the death of a child about a difficult and unpleasant procedure, the postmortem itself. In a coroner's case, the coroner directs the postmortem. It is mandated the family have no opportunity to say no. Where the coroner is not involved, it's frequently referred to as a house case. In those circumstances, it is done only with the family's consent. those two terms can produce a slightly different tone in the room when you're discussing with the family the procedure that's about to be undertaken. It's obviously a sensitive subject at a sensitive time, and it is clear that mistakes or misunderstandings at that time are amplified by the emotion of the occasion. I won't have to tell many of you in the room about the aftermath of the Bristol Hospital inquiry into cardiac deaths in children in 1999, because most of the next 5 years were spent dealing with the widespread disquiet that resulted about the perceived gap between parental understanding and routine post-mortem practice. In Ireland, this scandal produced the Madden report in 2005, which said that the information deficit between what the families were told and what was undertaken by the pathology department was not malevolently motivated and was due to a culture of the time. They recommended legislation covering this area, which we note is still awaited, like the new DOL. And they recommended modification of consent and information procedures to close that gap. The HSE guidelines we mentioned earlier give specific direction about the nature and extent of information to be delivered, and they give specific direction about the logistical management of those records. As yet, they're not inspected, but I'm sure they will be. I mentioned that the pathologist in Crumlin has a role in the follow-up next of kin clinics, but as Eleanor mentioned, we now, and since the year 2000, have been the primary source of information for families before a post-mortem. We meet to explain what's going to happen, and it is the pathologist who completes the necessary paperwork. That began not out of some ambition to be involved in this difficult process, but because of a failure of the existing process to do what was necessary. So a pathologist is introduced to the family by the clinical staff, goes through the information and completes that paperwork, and it is a difficult conversation. But in our opinion, it results in a clarity and a lack of ambiguity for parents and pathologists that is beneficial to both. With 15 years' experience of doing it, I no longer regard consent as the most appropriate word to describe that interaction. The pathologist explains the procedure, describes what will be done and how, negotiates with the family the extent of the procedure, describes hopes and expectations for it and limitations for it, and negotiates the timing of it and what the family wants to happen around it. And after that negotiation between two equal sets of adults, we agree terms under which an examination will be undertaken. A better and more honest depiction of that conversation is that at the end of it, the family requests that the pathologist undertakes that examination under those terms, and the pathologist is the one who agrees to do it. I've suggested before to Dr. Madden and others that we should replace the consent form with a request form, and that the onus should be switched around. He's been reluctant to incorporate that, but I think that's a more intellectually honest depiction of the conversations that we now have. Since the introduction of that method, we've had very rare circumstances under which families have expressed unhappiness about the post-mortem procedure. So despite being the focus of that attention back in 2000, it's no longer an area of major concern in the hospital. We do have slip-ups. The principal slip-ups involve misunderstanding about the relative position of the coroner. And with each new influx of non-consultant hospital doctors, one of the things we talk about is where the coroner fits in this process. So I present the new doctors with this little algorithm, CCF, which they're used to regarding as congestive cardiac failure from their medical student days, but in this circumstances, it's asked them to consider the circumstances of the death of a child and to reflect whether any of those circumstances warrant contacting the coroner. And then, and only then, having heard back from the coroner, do you discuss with the family the possibility of a post-mortem. The slip-ups that have occurred are circumstances where a well-intentioned medical professional has mentioned a post-mortem to a family, the family have declined, and then, some hours later, the medical professional has recognized that actually it should have gone to the coroner first. The coroner directs a post-mortem, and the family then very reasonably come to the conclusion that the hospital and the coroner have conspired to overturn their wishes. If we follow that logical order, that circumstance has never arrived. So when is the coroner involved? Well, he's involved in rule of law under these Coroners Acts, and we could summarize it in a single sentence, really. In circumstances where the cause of death is unknown or where, by some stretch of the imagination, it could potentially be somebody's fault, referrals are also made by rule of good practice, and we could summarize those in a single line by saying it really is a series of common sense applications usually agreed with a local coroner. Well, I know that we have staff in the room here who come from all parts of the country, and I have to point out that in many coronial districts, the coroner is a local GP or a local solicitor. And in both circumstances, it's very unlikely that that professional carries the sufficient knowledge to make informed decisions in all cases. It's sad to acknowledge that there is not much sense, common sense, in the coronial community across the country. We're very fortunate here in Dublin with Dr. Brian Farrell because he is dual qualified as both a barrister and a pathologist. But decisions made in some jurisdictions around the country do leave a lot to be desired. It's therefore very important that healthcare professionals record their contact with the coroner. Why did we refer the case? What did the coroner direct? And once referred to the coroner, it's very important that we recognize the coroner is in charge. If you have not heard the coroner's direction, it does not mean you are back in control of the remains. The coroner is in charge until their decision is reached. And again, an occasional mistake happens when a body is released while the coroner's decision is still pending. So we can see that following the death of a child, communicating with the family, communicating with the coroner, there are a multiplicity of tasks for a multiplicity of health professional groups. And an audit undertaken in Crumlin some years ago suggested that all of these tasks were not necessarily being completed, or if they were being completed, they weren't necessarily being well documented. So in response, we produced a series of algorithms. And the algorithms are direction for the following professional groups dealing with the death of a child. Here's the medical algorithm. I don't expect anyone to read the message. Essentially, it poses a series of questions, the answers of which direct you down different pathways, instructing you what to do next. There's no ambiguity when you follow this particular diagram. Nurses are excellent at following algorithms. My impression is most nursing staff quite like them. Medical staff are always suspicious of algorithms. They believe they have a downside and often are characterized by medical staff as a tick box exercise that negates any independent thought process. I agree with the nurses that they have an upside, which is that they are a tick box exercise that negates any independent thought process. That means that you stop wasting time trying to think and remember what you're supposed to do next, and you can get on with your main job, which is caring for the child and the family. If anybody wants to see these algorithms, we're happy to provide them to you. I think they've been a singularly helpful addition. They're not perfect. They will become perfect, I think, when we move to an electronic chart, and they are accessible in all parts of the hospital, but they are certainly an improvement. The final topic is Inquest, and this takes place some time afterwards. But communication with families suggests they remain a topic that can be a source of grief and discomfort, so hence I've covered them in this talk. So an inquest is held by law to any unnatural or violent death, and in practice by any death in custody or work-related. However, there are a consistent trickle of cases of death occurring in the hospital setting that are brought to inquest, and they are overrepresented in press coverage of inquest, as we all know, to our cost. The purpose of an inquest, according to the Coroners Act, is to determine the medical cause of death, to allay rumour or suspicion, to draw attention to circumstances which, if not remedied, might lead to further death. And this is the clause that the coroner usually refers to when he refers a medical-related death to an inquest. It's also done to advance medical knowledge and to preserve the legal interests of the deceased's family. The outcome of an inquest is to establish who, when, where, and how the death occurred, but the coroner is not allowed to censure any professional who he feels has contributed to the death, nor is he allowed to exonerate any professional when the evidence suggests it was not their fault. He will frequently add to his verdict a component of legal or journalistic commentary. The verdicts are very limited. Most of them don't apply to a hospital setting. We tend to get involved mostly in death by accident, which is where death has occurred as a result of an unintended action, or misadventure, which is where the death is a recognized complication of an intended action. He sometimes refers to medical accidents when the death is something that's not a recognized complication and clearly represents a medical error. But the range of verdicts is nonetheless quite limited. The inquest experience, and I don't know whether many of you have attended inquests, but obviously families of bereaved children frequently do. It's a grand theatre. It takes place in a formal courtroom with all the pomp and ceremony that goes with that. And your experience is entirely dependent on your role in the play. The cast of characters includes the coroner, legal teams, the hospital, and the parents. And the clinical consultants who've been present at inquest will recognize that they have very little courtroom experience, that the experience can be profoundly intimidating, where your care and your clinical judgment can appear to be on trial. The family often employ a solicitor or a barrister to ask questions on their behalf, and it's difficult not to perceive that barrister as your adversary in the course of giving your evidence. There's frequently a hostile press in the room, and there's a stark contrast between discussing the case in a courtroom environment than in the normal clinical conference setting within a hospital. Some inquests have resulted in physicians being referred to the medical council or to the director of public prosecutions. Section 38 of the Coroner's Act includes a specific clause which says that a witness may feel that they will decline to answer questions in circumstances where their evidence will self-incriminate. It's the equivalent of the American Fifth Amendment, so beloved of Hollywood movies. Now, it's difficult to envisage when they wrote this act that it would be used to facilitate physicians refusing to answer questions on the care of a child, but it's no longer ridiculous to envisage circumstances under which that may happen on legal advice. A nurse giving evidence to an inquest, it's a potentially overwhelming experience. Happily, we now do have independent nurse practitioners, but for many nurses, they will have no experience of practice leading a medical team. The same applies to an NCHD. If you place a nurse or a non-consultant hospital doctor in a courtroom environment facing a senior counsel, it is not a fair contest. It's on his home territory, and you are away from home and frequently out of your depth, as are most of the clinical consultants placed in that circumstance. There are positives for the family. The family are provided with a forum in which they get answers they perceive have been elusive over the years since the death of a child, that these answers are retrieved by their barrister or by the coroner. It also provides an opportunity for closure, and the coroner here in Dublin, I think, is very good at recognizing that the inquest can play an important role in closing a family's bereaved process. There are negatives for families, though. This can take an incredibly long time to occur. It's traumatic to revisit the events in forensic detail. The limited nature of the verdicts I've talked about can be a real frustration to many, and because this comes at the end of a long series of meetings with the hospital, they may not hear anything new at all, and their hopes for the inquest may be dashed. The hospitals dealing with an inquest have a huge amount of data to prepare. They've become longer and more complicated. They're demanding in time, personnel, legal team, money, and they are emotionally draining. It's clear to recognize in the hospital when there's an inquest on that refers to hospital staff. Everybody is affected by it. We're all aware that audit has many forms, and one of the audits that's frequently done in clinical care teams is a review of an adverse event, where after the death, say, of a child, the event is reviewed, the practices are reviewed, we compare with what we would hope to have done, and we try and do better the next time. Such adverse event reviews become paper documents, and they're often the subject of public scrutiny. It's important to remember there is a radical difference between identifying opportunities for improvement and deficits which contribute to outcome. Opportunities for improvement are where the delivered care is consistent with good practice, but there are still things we could do better. Deficits which contribute to outcome is where the review suggests that the delivered care was not consistent with good practice, but the press frequently confuse these two aspects. It's appropriate that such reviews are made available to the coroner as part of their deliberation. It is also appropriate that they should be made available to families. But it is clear that there is a potential conflict between the family's right to have all of this information and the hospital's ambition to do a thorough, transparent, and revealing assessment of what may or may not have gone wrong. It's abundantly clear from many public places, including, most notably, the recent deaths of babies in the Midlands, that hospitals have got this balance wrong. We're going to have to do better. Without excusing those mistakes, the inquest process has definitely contributed to it, because an inquest is an adversarial event. It's a disincentive to a neutral ambience in which you are most likely to find the truth. It cultivates an us versus them atmosphere. I would propose that this is a better setting for an inquest, where we sit down in a non-adversarial roundtable discussion, not in a courtroom, where it's chaired by the coroner and the family are accompanied by their personal GP or advocate and not a solicitor. That's the environment in which we will learn the lessons of a death of a child when it's referred to an inquest. But what about learning the lessons of a death of a child when there isn't an inquest, which is the vast majority of circumstances? 100 years ago, this weekend, that document was read in front of the GPO, and it contained the sentence that we should cherish all of the children of the nation equally. I propose a 2016 proclamation that the state values the life of every child and regards the death of every child as a seminal event that should be investigated to identify any failings that contributed to it, any deficits in the support for the family enduring it, and any learning opportunities that might prevent the recurrence of either. Arising from that proclamation, here is a proposal. The state should demonstrate its commitment to cherish its children by collecting and interrogating information on the death of all its young citizens. In the 1990s, if there was a death from a road traffic accident, the Gardaí used to clear the road quickly to get the traffic flowing again. Now, they close the road and they investigate it thoroughly to learn all that could be learned to try and prevent a recurrence. In medical circles, we don't even reach that standard. There are isolated circumstances where it does happen, the rare cases that go to inquest, where a death has occurred of a child under the care of the Child and Family Agency, there is a review. The National Perinatal Epidemiology Centre that Eleanor and her colleagues contribute to provide excellent information about peripartum deaths and perinatal deaths. But there's a large number of deaths of children in the country for which there is no central information or analysis. I'd like to propose a new algorithm, and the algorithm invites us, when faced with the death of a child, to ask just two questions. Has there been prior involvement of this child in health or social services? And are there, after assessing the circumstances surrounding that child's death, are there concerns or learning points? I would suggest that the system has an opportunity to learn from such an algorithm being employed. And that if we persistently and diligently ask those questions when faced with the death of a child, we will improve the system competence and thereby improve the family's experience. If we are lucky, we may even prevent some of those deaths occurring at all. Thank you very much.